Good afternoon and welcome to our webinar, The Affordable Care Act, Getting It Right for Maryland's Kids, which is jointly presented today by the Maryland Women's Coalition for Healthcare Reform, Advocates for Children and Youth, ACY, and the Maryland chapter of the American Academy of Pediatrics. I am your host, Sandy Kick, Health Policy Analyst with the Coalition. Today we are excited to present this webinar to Maryland pediatricians so that they have the opportunity to get informed about the Affordable Care Act, how it is being implemented in Maryland, and opportunities to get engaged. We will hear from our speakers and then host a Q&A session before wrapping up today's webinar. Please note we have muted all phones during the presentation portion of the webinar, but we'll provide you with instructions for asking questions when we get to the Q&A portion of the webinar. This presentation is being recorded and will be posted within 48 hours on the Coalition and MDAAP websites. Now it is my pleasure to introduce Dr. Scott Krugman, President of MDAAP and Chairman, Department of Pediatrics at MedStar Franklin Square Medical Center, who will provide context and get us started with today's webinar. Dr. Krugman, you may go ahead.
Thank you, Sandy. On behalf of the Maryland chapter of the American Academy of Pediatrics, I'd like to thank everyone for joining us today, and I'd really like to thank the Maryland's Women's Coalition for Healthcare Reform for giving us this opportunity to partner. It's a very important topic that pediatricians need help and guidance to learn about, and a lot of us, including myself, are definitely in the learning mode. So if we go to the first slide, just a brief background. I don't know exactly if it's all pediatricians online, if there's anybody else, but to remind people that the American Academy of Pediatrics is a large professional organization representing 60,000 pediatricians across the country. And the AAP has a very strong advocacy component to look out for the well-being and what's in the best interest of children. And part of that is, of course, healthcare reform and making sure that all children have access to affordable and equitable and high-quality healthcare. And we were a strong component and made a lot of lobbying efforts for the ACA, and now we need to continue those efforts to make sure that the Act is implemented in the way that we need it for children. You can go to the next slide. The Maryland chapter of the American Academy of Pediatrics is our local representation. We have over 900 members, and we do a lot of work in Annapolis around state advocacy, as well as education and support of pediatricians in practice. And we see the Affordable Care Act as a area in which our members do need help, and you can switch to the next slide. And to do so, we recently just formed a task force, and Jackie Duget, who has helped spur this call on and help organize this webinar, is going to be working with Tina Chang, Dr. Tina Chang from Hopkins, to put together a group that's meeting at the end of this month. That information will be on our website as well if anyone is interested. But we have been partnering with DHMH around implementation issues, around making sure that kids are included in essential health benefits, and making sure that we do get as many children enrolled as possible into having health insurance. Our lobbyist Pam Casemeyer is very involved as well, and if anyone has any questions specifically about what we're doing, she is a great resource as well. So that is sort of the context for the Maryland chapter of the American Academy of Pediatrics. We are happy to be part of this, and we are happy to be working with this coalition to help advance healthcare for kids. So with that, I'd like to introduce our first speaker, and someone who knows a lot more than I do, Lenny Preston, who's chair of the Maryland Women's Coalition for Healthcare Reform. Lenny, you're on.
Thank you, Dr. Krugman. I can't thank you enough for the opportunity to partner with MDAAP. And if we go to the next slide, we are for those who aren't familiar with us, we're a nonpartisan alliance of thousands of individuals and 95 statewide organizations, and this is my pitch, we would love it if MDAAP would become a member. We do work very collaboratively with lots of policy experts and advocates around the state to ensure that everybody in Maryland has the health care they need and deserve, including all of our kids. And we work in multiple areas, policies, legislation, education, obviously this webinar and many others we've been doing, including later in October we'll be doing one on culturally competent providers. And then we do outreach and engagement, advocacy, and action. And we have a number of important partners who have helped with funding the organization, including the National Women's Law Center, Open Society Institute in Baltimore, and Raising Women's Voices for the Health Care We Need. And we currently have a contract with the Department of Health and Mental Hygiene where we're working on access to care forums. So we're out there in a lot of different areas. Today's agenda, we're just going to look, I'm going to provide an overview of the Patient Protection and Affordable Care Act, talk a bit about the essential health benefits and the new Maryland Health Connection, a sort of quickie overview of how Maryland's doing. We're really the lead state in the country. And then I'm going to turn it over to probably Maryland's foremost expert on kids and health care, Lee Cobb. So if we can go to the next slide, let's just start by saying we all know we're not there yet, right? In Maryland, we have some 730,000 uninsured, which is 13% of the population. Of those, 61,846 children are uninsured at any point in time, and the total of those under 18 without health insurance, 4.6%, way too high a number. And you can see on the slide the breakdown of the uninsured by race and ethnicity, with the highest percentage being the Hispanic Latino kids. And let me say that these slides, the whole PowerPoint presentation is going to be up on mdhealthcarereform.org, so you'll be able to come back and look at these. Nationally, I think it's important to point out that approximately 10 million children and adults are living with mental illness and have no insurance, and 46% of adults spent part of 2012 with either no insurance or inadequate coverage. And we all know that those in the lower income brackets are far more likely to be uninsured or underinsured, which is equally dangerous because before the Affordable Care Act passed, of course, we had people who were losing their houses and losing their lives for lack of insurance. So the next slide shows you just a regional picture of what the uninsured looked like today, with a breakdown on race and ethnicity. So let's talk now about the Patient Protection and Affordable Care Act, which I think of as a three-legged stool because I happen to love this slide. But the first leg is really everybody's in. There's non-discriminatory insurance coverage, can't be denied because of a pre-existing condition, which I would argue is most of us. And it expands Medicaid and provides for qualified health plans to be sold at what is called, for us in Maryland, Maryland Health Connection. Second leg is that personal responsibility. We have a responsibility to be insured, and that is the piece that the Supreme Court found constitutional in June of 2012. And the third leg is the affordability. So let's look first at the patient protection part of it. When they designed the law, they really put this piece in first to kickstart the effort, knowing that the affordability piece was going to take some time to get up and running. So right now, probably one of the most popular patient protections is the fact that young adults can stay on their parents' health plans until the age of 26. So those kids coming out of college who can't find a job can have insurance under their parents' plans. There are no lifetime or annual limits on essential health benefits for children right now, and adults. That kicks in on January 1st of 2014. The same in that now there are no pre-existing condition exclusions for children, so important, and that begins January 1, 2014 for adults. And we'll talk more about this expansion of Medicaid coverage for former foster youth. No longer can insurance companies arbitrarily cancel insurance just because you get sick. Preventive care without copays and deductibles, which I'll talk about next. No pre-authorization required for an ER visit, and that donut hole for us seniors is closing. So let's go now. I have to give a shout-out always to Senator Barbara Mikulski, who put into the ACA, as we affectionately call it, the Women's Health Amendment, which ensures that women get those preventive care services without copays and deductibles. And we know that some 37% of women were going without mammograms because they couldn't afford them. So this is incredibly important. Provides women with a well-woman visit, gives them, from a pediatrician's point of view, the important access to breastfeeding support, family planning services, including contraception, screenings, mammograms, and HPV testing, all critically important. So now let's go to the affordability piece. And let's just move past this slide. The next one gives a little more information on the first piece of that, which is the Medicaid expansion. And Maryland's, I'm sure that you know that many states, 22, have decided not to move forward on the Medicaid expansion. 4 are still debating the issue. But Maryland's approach was, why would we turn down millions of federal dollars to ensure that we have our residents covered with health care coverage? So the expansion takes it up to 133%, but there's a 5% financial set-aside. So it's 138% of federal poverty, and you can see what that means in dollars for individuals and for families. There's going to be a simplified eligibility and enrollment process, no asset tests. Right now, Medicaid is pushing to get the primary adult care enrolled, those who are eligible actually enrolled in the PAC plan now, because that means on January 1st, 2014, they automatically roll into Medicaid. They don't need to do a thing. This is so important. And then also we pushed Lee Cobb and others very hard to ensure that foster youth up to the age of 26 can be covered under Medicaid. And if individual families can keep their children covered, then the state, as the parent of foster youth, has that same obligation, and I'm glad to say that Maryland recognized that. So then the benefit package for Medicaid will remain the same, and there will be basically a no wrong door to access first health care and then ultimately all social services. So, and you can see the enrollment projections. For 2014, the goal is 108,000 and moving up in 2020 to 187,000. So then for those who are between the federal poverty level of 139 and 400% of poverty, they will qualify for financial assistance in the form of advanced premium tax credits so that they can buy qualified health plans at what will be Maryland Health Connection. And those are going to be sold at 4 metal levels that are based on actuarial value. And there are also additional cost-sharing subsidies to help pay for the insurance needs. And if you or somebody you know wants to find out today what the level of their subsidy might be, what they might be eligible for, we included a really useful tool here that you can take a look at. So let's go to the next slide. So what's going to be sold here? So the Medicaid benefit I mentioned is going to remain the same. I think it's very important for people to understand as they think about the cost of these plans that every plan in the exchange will have to meet an essential health benefit benchmark that covers these 10 buckets that you see. These are really more comprehensive plans than many people have been able to access in the past. For example, maternity and newborn care is covered only in about 30% of individual plans today. So in future ambulatory patient services, emergency services, everything you see here will be covered, and very important, access to mental health and substance use disorder services. And you will also note the pediatric oral and vision care that Lee is going to be talking about in just a minute. So the insurance carriers have submitted their plans to the Maryland Insurance Administration, and I'm pleased to say that we have an MIA with a lot of clout. And so they have been ensuring that the plans submitted had adequate number of providers in each network, including those for mental health and substance use disorder. They have to contract with essential community providers who serve medically underserved populations. They have to comply with the Federal Parity Act, and they have to provide continuity of care provisions that go into effect in 2015. And Maryland has come in with some of the lowest insurance rates in the country. So they've done a great job on this. Now, the plans themselves will be sold at the Maryland Health Benefit Exchange is its formal name. That's the governance administrative name. And then the website where people can go is Maryland Health Connection. A one-stop shop that's been established through legislation, and I think it's very important to point out that Maryland determined very early on we wanted our own state-based exchange. And this has given us an opportunity as stakeholders, including MDAAP, to weigh in on what our exchange will look like. So here you'll go to determine what you're eligible for, what the plans that are going to be available to you are, and you're going to be able to search for those based on the premium and copays, on the actual performance of the plans. The only one that won't have quality measures at first will be the Evergreen Co-op. And then people will also be able to search by their provider network so they can be sure that their own provider is part of the plan that they choose. And they'll be able to compare these plans apples to apples. And I'd like to say when you're in that market aisle looking at those apples and you can't decide between a Fuji and a Rome, there are going to be real live people to help you. There's a website we'll put up in a moment at marylandhealthconnection.gov, and then there's also a call center where people can go for care, for assistance. So if we go to the next slide, this shows you what the plans are that can be sold in the individual exchange, which include Care First and the new Evergreen Co-op, and Kaiser Permanente and United Healthcare. And then there will also be standalone dental plans. And as well in Maryland, we're going to have what's called a multi-state plan that's also going to be a Blue Cross Blue Shield Care First plan. So where are people going to go? MarylandHealthConnection.gov. You can go there today and see what it's going to look like. And we are 17 days away from open enrollment when we go live. You should be seeing ads around the state. I haven't seen them down in Montgomery County, but I know the radio ads are up in Hartford for one. And so people will go there to determine what they're eligible for and to start the enrollment process. And then January 1st of 2014, the full benefit plans start. Besides an individual exchange, there's also going to be one for small businesses. They'll be able to get tax credits, and that small business or shop exchange, as it's known, will also open on January 1st. And we put up a link to a video where you can also learn more about Maryland Health Connection. I just want to go to the next slide, which there is a customer call center that is open now where people can go and get information. And on October 1st, those hours you see on the screen are going to expand, and they're also going to be open on Saturdays. And so how are people going to get through the maze of the eligibility and enrollment process? So if you take away nothing else from today, outreach, 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 and education. And really, as providers and everybody on the call, our role as educators, whether we're standing in a grocery line or you're in your office, is to let people know about this incredible new opportunity. And there are lots of avenues for that eligibility determination and enrollment process. And so I'm going to turn it over now to Lee Cobb. She is the Health Policy Director for Advocates in Children and Youth, and she's also serves as a critical member of the Coalition Steering Committee, and we couldn't have anybody better to join us to talk about the Affordable Care Act and children and what's happening in Maryland. So thank you, Lee.
Well, thank you, Lenny, for that terrific overview and introduction. I'm Lee Cobb, the Health Policy Director at Advocates for Children and Youth, and you have before you a synopsis, a little bit about ACY. We have been around since 1986. We cover we work across 4 different issue areas, including education, child welfare, juvenile justice, and health. We have long work to expand access to health care coverage for both children and their families. And one thing that ACY identified years ago as being critical is a no wrong door approach to enrollment. The good news is that Maryland has really used the Affordable Care Act as an opportunity to move towards that goal of a no wrong door. Starting in October, the new HICS Health Information System will be up, the Maryland Health Connection, and at starting in October and then in January, it will include the Medicaid expansion, Medicaid for families, CHIP, and of course the new qualified health plans available on the exchange. But moving forward, and by the end of 2015, all income eligibility programs will be able to be accessed through the Maryland Health Connection. And that is a really terrific thing for Maryland. So it will eventually include WIC and food stamps and other programs. So not going to happen right away, but we've got a terrific federal match to make that happen, at which I'm proud to say Maryland has taken full advantage of. So as Lenny said, outreach, education, enrollment are key to the upcoming months. And as she mentioned, the Connector program is through the Maryland Health Connection. The Maryland set up this program with regional connector entities. There are 6, and Sandy will get to that slide in a minute. But the important thing to understand is that individuals, certified navigators who will be trained, and assisters will be employed directly by the connector entities, and there is one connector entity in each of the regions. In addition to the regional connector entities and the local Department of Social Services and local health departments, Maryland has a statewide call center, and in addition, insurance brokers, sometimes called insurance producers, will go through a training and authorization process, and so they too will be able to sell qualified health plans on the Maryland Health Connection. So moving to the regional connector entities, I know this slide may be a little hard to read, but they are contiguous regional areas across the state of Maryland, and you will see listed next to each of the regions is the name of the connector entity that received the grant from the state of Maryland to function as the connector entity. Each of these connector entities is partnering with community-based organizations. I believe Healthcare Access Maryland in the central region has some 27 partners. Some of the other areas have a few fewer because they're smaller. But the important thing is that there will be people on the ground who are familiar with communities, particularly those at-risk communities where there is high uninsurance, and will be therefore trusted ambassadors, if you will, to help assist people get enrolled. So as part of your takeaway, please understand that folks do not have to enroll online, although they certainly can do that, nor do they have to use the call center, but they can actually get help, one-on-one assistance in the community. As you might imagine, the training and certification areas are somewhat complex. The navigators and assisters are being trained, given training on general knowledge around the Affordable Care Act, and also a background on who the uninsured are in the state of Maryland. We certainly want to make sure that the navigators and assisters are all culturally competent. All navigators, assisters, brokers, call center personnel, and others will have to understand this new HICS eligibility and enrollment system, and they will receive training on that. As I mentioned, cultural competency and health literacy are particularly important issues. For many folks, who are currently uninsured. They have not had insurance in the past, or if they did have insurance, they had Medicaid insurance, which was somewhat simpler than commercial health insurance, where one has to make a selection among metal levels and really understand how to access coverage, but also understand premiums, deductibles, cost sharing, the whole 9 yards in terms of what we sort of call health literacy or health insurance 101. Certainly these navigators and assisters have to understand the medical assistance programs, which include Medicaid, but also the CHIP program for children. And as you may or may not realize, Maryland had the foresight years ago when the federal Children's Health Insurance Program was passed to implement that as an expansion of Medicaid. That means for children and families enrolled in Medicaid or MCHIP, it's essentially seamless between the two. The state receives a higher match for kids in CHIP than it does for kids in Medicaid, but families are unaware of the back end, if you will. So, moving on, as Lenny mentioned, there is help for folks purchasing whose income is above the 138%. Between 138%, folks are Sandy, if you want to back up, are eligible for advanced premium tax credits, and that essentially means that the tax refund that folks would receive in April is available a year in advance, more than a year in advance, to help pay for premiums on a monthly basis. That is somewhat complicated, and there is a calculator that helps navigators calculate what the advanced premium tax credit is. But it's important for folks to understand that if income changes, that they need to let the navigator or the connector entity, the new health system, understand that so that they don't owe the government anything at the end. Qualified health plan selection is another piece that navigators will receive training on, and navigators and insurance producers and call center personnel will all be able to answer questions on the qualified health plan selection. As Lenny mentioned, there are 4 different metal levels. For young adults under 30, in addition to those 4 metal levels, there are catastrophic plans, but it's very important that folks understand exactly what a catastrophic plan covers. There are no advanced premium tax credits for catastrophic coverage, and so for many young adults, while catastrophic may look cheaper because premiums are less, so is the coverage, and it's important that they think through and perhaps have help thinking through their options. So moving on to the next screen, one of the very good things about the Affordable Care Act is it really emphasized the importance of preventive services. And the preventive services listed on the website on the slide 2 of this list is a compilation of preventive services that are available for free. The services do track the AAP's Bright Futures guidelines, which is terrific news. And so these 2 slides give you an idea of what's on the list. There are more details on the federal website and on the AAP website as well, but it gives you some ideas of it. It covers well child care screenings, including obesity, depression, HIV screening and sexually transmitted infection screening for adolescents, as well as vision. So you can peruse that list on your own. There are, as Lenny mentioned up front, one of the 10 essential health benefits is pediatric. Sandy, I think we need to go to the next. Thank you. One of the complications surrounding children's access to services, and this is not just through the Maryland Health Connection, but nationally, has to do with pediatric dental benefits. And I'm happy to discuss this further offline, but The good news is that pediatric dental benefits were identified as essential health benefits under the federal law and Maryland state law, and follows the federal ACA. That's the good news. Unfortunately, the ACA includes pediatric dental benefits, but not benefits for adults. And that had some ramifications in terms of how dental benefits were rolled out. As part of the ACA, dental benefits are offered through standalone dental plans, and Lenny showed you earlier a list of insurance carriers that were offering standalone benefits. But benefits may also be offered through embedded plan or embedded in a medical plan. And in Maryland, of the 45 plans that are going to be offered as qualified health plans through the Maryland Health Connection, 36 of those plans offer embedded dental benefits for pediatric dental benefits. So we're really excited about that. It may be that the lowest priced plans do not include embedded dental benefits. Folks will have the opportunity to purchase pediatric dental benefits through standalone plans, or they might have to pay extra for pediatric dental benefits through a particular medical plan. For example, the providers they want to use may all be associated with a plan that does not include embedded pediatric dental, so they might make that selection and decide to pay extra through a standalone plan. It's important that as people look at their options, they understand pediatric dental options as well as everything else. And one of the reasons is that in the standalone option, there are separate and therefore additional maximum out-of-pocket costs for pediatric dental. So it's just something, and I know it's definitely a complication, and we certainly hope that the navigators and assisters will be able to answer questions on this. I know the training process is up and running now, but it is more complicated partly because of federal regulations around this issue. So happy to take questions about that, further questions offline, if any of you have those. Moving forward, providers and pediatricians in particular have always been identified, and fairly recently in a poll in Maryland, as among the most trusted resources for families. And that is certainly going to be true with choosing and understanding options for health care coverage. So it's important that you all understand that all plans purchased through the Maryland Health Connection must cover doctor visits, hospital stays, preventive care, prescriptions, and much more. Some of that list is you saw before, and of course you saw an outline of the preventive services for children. Low-cost and free plans are available for children and adults, and financial help is available based on income. I referred to the advanced premium tax credits. There are also additional subsidies for families earning under 250% of poverty. However, to access those services, they must purchase a silver plan through the exchange. However, in so doing, with the additional subsidies, the silver plan will actually be much less expensive than the bronze plan would be. The good thing about the Maryland Health Connection is that it will have side-by-side comparisons of each of the commercial plans offered. That is really something that's been needed for a long time, and as Lenny said, it allows a true apples-to-apples comparison. We anticipate that depending on circumstances, that families will have multiple coverage options. For example, one parent might be covered through their the employer, while the other parent might have to purchase individual coverage through the Maryland Health Connection, while the children would be covered by MCHIP or MCHIP Premium. As you may know, probably know, that CHIP and MCHIP premium go up to 300% of poverty. Between 200 and 300%, there is a small premium charged to families, but that premium would be much less than paying for individual coverage through the exchange. I think it's fair to say that the best option for children and families under 300% is Medicaid or MCHIP, or the MCHIP premium, and all three of which provide EPSDT benefits, which include dental services. So there's no question of paying extra for pediatric dental if your child has coverage through MCHIP, Medicaid, or MCHIP premium. Next slide. One of the questions we frequently get has to do with immigration status and what services and coverage options are available for immigrants in Maryland. It's important to understand that naturalized citizens are eligible for everything that someone born in the United States would be eligible for. So that includes the public programs, Medicaid and MCHIP, and also the qualified health plans with the advanced premium tax credits. Now, as before, as right now, after 2014, all documented pregnant women and documented children are eligible for Medicaid and MCHIP, and so that includes pregnant maternity benefits for women. Other documented immigrants, however, must have lived in the United States for 5 years before they can apply for Medicaid. However, this 5-year waiting period required by Medicaid does not apply to the purchase of qualified health plans through the exchange, nor does it apply to eligibility for advanced premium tax credits to help cover those premiums. With respect, we do have a number of areas of concern. One of them is continuity of care if families change, providers change coverage options. Another is churn. Churn is a term of art, if you will, for folks that lose coverage because of a change in eligibility perhaps for Medicaid, and then takes time to find other coverage. The intention of the new Maryland Health Connection is that there will be no churn, that people will be able to smoothly move from one coverage option to another, but it's certainly something we want to closely monitor. We have, as Lenny mentioned, Maryland's rates appear to be lower than anticipated and lower than other places in the country. That's really terrific news, but we certainly want to make sure that families are able to access the coverage options available to them, and so we're going to be closely monitoring that. Premium payments for those who have not had commercial insurance before, what may be a new thing, and folks will have to make provision for regular payments that are not covered through the advanced premium tax credits. I mentioned standalone dental and pediatric dental coverage. I think Lenny views this as a black hole every time I begin to discuss it. So, one day it would be wonderful to have adults covered under Medicaid and have adult dental benefits as part of an essential health benefit. It would make the system so much easier. I will talk a little more about pregnant women under 250% of poverty because we actually have a slide on that. We are thrilled at ACY, as are other advocates in Maryland, that there is this new provision for former foster youth. What it means is that former foster youth opportunities will more closely parallel those of children who can stay on their parents' plan. The good news is former foster youth are eligible starting January 1st for full Medicaid benefits regardless of their income, and they will be eligible up until they turn 26, just like their counterparts who are on their parents' plans. The difficulty is that many of these kids have aged out over the past few years, and they will be eligible, but because they are no longer connected to the foster care system or social services, they may not know about these benefits. So one thing ACY is doing is getting the word out to former foster youth So to the extent that any of you treat former foster youth or work with foster families in any way, it's important that you understand this new opportunity for former foster youth. Health disparities has been an issue in Maryland, and it's something that the ACA has the potential to address. But again, it's something that will need monitoring and good data collection. Unfortunately, undocumented children, as with undocumented adults, are not eligible for coverage through Medicaid CHIP or through the new exchanges or the Maryland Health Connection. There will still be services through local health departments to address their needs, but it does emphasize that we need to make sure that we have a robust health safety net to cover those who live in areas where there are simply not enough providers, but also those who do not have access to coverage because of their immigration status. And children with special health care needs are an ongoing concern. I think the good news is that their families may have more opportunities for coverage as we move forward. The next slide sets forth some of the issues around pregnant women under 250% of poverty. Right now, if one were to go to the Maryland Health Connection, or I shouldn't say right now, in 17 days, and one was under 250% of poverty, you could, of course, a woman would be eligible for Medicaid right now, and that will be true starting in January. So to the extent that a family were to apply for coverage through the Maryland Health Connection through the exchange because they were over 138% of poverty, they were pregnant when they applied, they would go directly into Medicaid. If a woman were to enroll in a qualified health plan because her income was between 138% of poverty, was over 138% of poverty, and she became pregnant, she would be eligible for Medicaid services and the enhanced benefits through Medicaid, which include oral health services. Unfortunately, at this point in time, women will have to self-identify that they've become pregnant, that they're in that eligibility category. Then they would be disenrolled from their qualified health plan, enrolled in Medicaid for the duration of their pregnancy plus the 60-day period postpartum, and then they would receive assistance re-enrolling into the qualified health plan. We have some concerns about potential churn with folks getting re-enrolled or understanding that they're eligible for these benefits. And moving forward, we hope to have the system will run a little differently. But at this point in time, it's important that pediatricians understand that women of childbearing age face this potential situation and help them understand the process. Additional issues to watch are certainly network adequacy. We encourage all of you to certainly take Medicaid patients to be involved with the Medicaid managed care system and the MCOs. But we'd also, a very important role for providers and pediatricians in particular is to give feedback as to whether people are able to access services, including specialists or other services within a reasonable time, whether the networks are really adequate, whether you, for example, are getting swamped by requests for appointments. Lenny touched on mental health and substance use disorder providers. Obviously, there is concern about network adequacy there. There's also concern with OBGYNs. Essential community providers certainly have a role to play moving forward as they have had in the past, and qualified health plans working in the exchange are required to contract with them. We just want to make sure and monitor that they engage a sufficient number of essential community providers. Then, continuity of care. Beginning in some commercial insurance policies have some continuity of care provisions, but they typically handle them differently. There will be a set guidelines beginning in 2015, and which all plans must honor. And this is going to be particularly important in the context of mental health, substance use disorder. It will also be important in the context of pediatric dental care. It is critical in certainly cancer care and many health issues, diabetes and others, where continuity of treatment is critical, and that it not be stopped just because of a change in either who the insurance carrier is or a change between coverage options. Provisions will include the lesser of 90 days or current course of treatment, but as you will see from the slide, it is not applicable when members transition from commercial carriers to Medicaid fee-for-service programs, but is applicable in the other direction. The state is working to improve how and to monitor how the continuity of care protections work moving forward. Access to affordable, culturally appropriate care is certainly critical in terms of health equity for Maryland. As we mentioned earlier, health literate consumers are something we need to grow in Maryland, and it's a place where providers can certainly have a role. There are a number of other state initiatives, including the State Health Improvement Process and Local Health Action Coalitions, also known as SHIP, the Health Enterprise Zones, and the State Innovation Model, including the Community Integrated Medical Home. There are also some health home models being considered or moving forward in Maryland. So the Affordable Care Act and what Maryland has done to implement it and what to grow around the act are really important opportunities to move forward to address fundamental health disparities and equity issues in Maryland. How can you get involved? Well, there will be a standing advisory committee that will get up and running in March of 2014. We hope certainly to have pediatricians represented on that committee. One of the things providers can certainly do is hold their insurers accountable, and that includes for the panoply of preventive services. The local health improvement coalitions, the SHIPs, are certainly opportunities for providers to be involved. I mentioned provider networks and the MCOs earlier, and it's certainly important for you all to be aware of what's happening in your community so you can link your patients and their families. So I think that about ends our presentation. And we're happy to take questions, and you will have both Lenny and my email addresses and other contact information should additional questions occur to you after the presentation. Sandy, do we have any questions in the
Thank you very much, Lee. That was terrific. We're now actually going to ask our techie, Zenobia, to give information on how people can ask their questions. So, Zenobia, do you want to go ahead?
Yes, thanks, Lenny. I'm now going to officially begin our Q&A session, so you'll hear an automated voice that will say Q&A session has started. If you'd like to ask a question, first hit *6 to unmute your phone and enter the queue. Or hit *6 to unmute. When you're prompted, press 1 to enter the queue. And then when you're prompted, state your name, your organization, and your question. And then Lenny and our speakers will answer your question. And we've already got some questions in the queue.
Great. Thanks so much, Zenobia. Let me just, before we take the first question, I want to just point out that what we're trying to do on October 1st of this year is an incredibly complex task with this new website and the IT systems that are behind it. I don't know if some of you may have seen the other day the story about the federal hub for all of this is ready, and the state systems have to connect with that, have to connect with the insurance carriers. So this is really a monumental task that's been undertaken, and I want to stress again how Maryland has really been in the lead on this, and really the governor, his administration, everybody involved has really picked up the baton and run with it. But that said, Carolyn Kotraki, the director of the Governor's Office of Healthcare Reform, always says that this is not going to be without its glitches. So there's a lot of promise with healthcare reform, and I personally just want to say we need to keep the faith as we start under this. There are lots of procedures and processes in place to address the known and the unknown as we go forward, and we really appreciate the fact that all of you have taken the time to join us. So, Zenobia, do you want to give us your first question?
Yes. Yes, hi. This is Dr. Ann Balowitz. I'm a pediatrician, public health person. I'm a mentor at Hopkins Hygiene and also chair of the Infectious Disease Committee with the Maryland AAP. Thank you very much for this tripartite presentation. It's been extremely helpful. Two brief questions. One is a point of definition. When you mentioned essential community health partners, if you could just clarify what entities that was referring to. And the second question is, if either a child or a family requires social work support, how would that be addressed in the framework?
Great. Lee, do you want to take those?
Sure. And I think both are very good questions. Thank you. I think you mean essential community providers, and because there's the partner component as well. Sure. But for the essential community providers, there is actually a federal sort of minimum definition, which includes, and I think the slide, if Sandy can go back to that, includes some of the traditional community providers, which would include Ryan White, would include Ryan White Family Planning, certainly federally qualified health centers. But there is the opportunity for states to expand upon that definition, and so, for example, school-based health centers could be included but have not yet been. So one of the things moving forward for Maryland, we need to really assess whether there are sufficient numbers of essential community providers, because we can expand the definition, the state can, and that's something that, the state has committed to considering if there are not enough participants.
Right. Where would FQHCs fit in under that rubric?
They count right now as an essential community provider.
As one of the subsets?
Yes, they do.
Okay.
They do.
Okay.
And, but that is, Lenny, perhaps we can provide a broader list of what else is in that.
There is we have a link to the website, and we'll include that in the resources when we post them. And let me just say that on my very first slide, I said, educate, advocate, and take action. This is one of many areas in which Maryland made a decision early on from a policy perspective to retain what's in place today and to collect data over the next year, 2, 3 years as the basis for making policy decisions. So the coalition and ACY and many others are going to be tracking what's happening here. And you all have a really key role here in keeping us informed. So not only do we want your questions going forward, but any information or expertise that you want to bring to our work so that we can make sure that, in fact, in future we can include school-based health centers or whatever else it might be in that definition as the exchange makes those decisions in the future. So I think, Lee, I'm sorry that I interrupted for the next answer.
No, that's terrific, and it will be. I do think we need to provide the link to the full list. So excellent question.
Great.
And but as for your second question about social work support, right now the programs that are more typically DHR related programs, and including food stamps, but also WIC and other services are not linked to the Maryland Health Connection, but in the future they will be. So there really will be one-stop shopping, a really true no wrong door. So navigators may well be able to tell folks that they could also be eligible for this or that, but they won't be able to actually enroll them at this point in time. But the state got a 90-10 match to build this new HICS system, including the social service component, if you will, the income eligibility component there. And so the state is absolutely, as it should be, planning to take advantage of that 90-10 match. So they've got to build it. It's got to be complete by the end of 2015 or the federal match goes away. So they are working on that. It's just not there yet.
Right. What I actually meant, and of course WIC, et cetera, are key as well to pediatric welfare, but if a child or a family needs actual therapy with or an assist from a social worker, a clinical social worker, would that fit under the rubric of mental health services,
yes.
Or is it covered in some other? It would. Okay.
It should fit under the rubric of mental health services, and one of the issues in community, because and there've been a myriad of discussions around that, because sometimes mental health providers include both the psychiatrist but also social workers on staff, but they will be covered under Medicaid and should be covered. But if that's an area where people run into difficulty with, we would certainly want to hear about it. And we do want to make sure that social workers get credentialed to be part of this system, that they get linked with the carriers and are part of the networks.
Great. Thank you very much.
Uh-huh. Zenobia, the next question?
Yes, here we go.
This is Michael Levitt, a pediatrician in Cumberland and Allegheny County. My question is, what is the role of the county health departments in the education, advocacy, and enrollment in the program?
So I'll just start, and Lee will probably kick in. So those regional, the connector entities that Lee described, many of them are partnering with the local health departments in the outreach and enrollment efforts, and there will be certified application counselors as well that are not part of the connector program but who have historically been in locations doing eligibility and enrollment. Lee, do you want to add on to that?
Sure. Michael, there are, as we mentioned, the 6 regional entities. Some of them are specifically health department based, including the one in the D.C. Prince George's County area. It's actually headed by Montgomery County, and all of them are partnering in some way with the regional connector entities. And there is also, beyond that, there is an absolute requirement that the connector entities work with the local health departments. Sometimes the connector entities will station a navigator at a local health department, but there is also, the reverse is also possible, that local health department folks get trained as navigators, as certified navigators to work within the health department. But right now, the local DHMH and DHR are both doing training for local health department staff and Department of Social Service staff. So they are involved, as they should be, on every level.
Yeah, and where you are, Michael, your connector entity is Healthy Howard.
Right.
my understanding is that they have a formal partnership with each of the county health departments, including Alleghenies.
Great. Thank you.
And Healthy Howard what is an outgrowth of the Howard County Health Department. So there's certainly a recognition there of how critical that relationship is.
Thank you.
Zenobia, the next question?
Yes, there's one more.
Okay.
Hi, it's Dana Silver. I'm a pediatrician at Sinai. Can you hear me?
Yes.
Okay, good. I just wanted to make sure I unmuted it. I'm a pediatrician at Sinai, but we're part of an FQHC. So I had two questions. One is with the possibility in Congress of delaying implementation of Obamacare for a year, that's being discussed, is that going to affect things? And then the other is more on a local level in terms of expanding Medicaid enrollments and things like that. Will the people on Medicaid still be allotted to the MCOs?
Let me take the first question and give Lee the second one. So the 40-plus votes that have been taken in Congress so far to defund Obamacare have all failed. And Senator Reid said just today that if there were something attached to the current bill, that would it wouldn't make it through the Senate, and it certainly wouldn't be signed by the president. I was at an event yesterday at the White House to roll out the new LGBT initiative, and Secretary Sebelius spoke, and as she said, Obamacare is the law, and so I don't think that there's any chance of completely derailing it.
Good.
And I should add, too, that before the Supreme Court made its decision in June of 2012, the lieutenant governors led the effort here in Maryland, was asked what Maryland would do if the Supreme Court found major parts of it unconstitutional, and his response was, we will not delay, we will continue to move forward. So I think, and we're well on the way to that. So hope that answers that. Lee, do you want to respond to that?
Right, and much of the money that Maryland has received a significant amount of money from the federal government through establishment grants and also to fund the new IT structure. We already have that money. So totally derailing it is really not a possibility on any level in Maryland. But there's no question that it sounds like it's a possibility in the press. But Maryland is definitely moving forward. We're opening. I mean, it will, as Lenny mentioned, there may be glitches, but we are moving forward, and the HICS system may not be perfect on October 1st, but it will be open.
Good.
But you had a second question too, right?
Just about will it stay the same in terms of if they're enrolled in Medicaid or MCHIP, that it will still be an MCO to which they're assigned?
Yes. Yeah.
Okay.
It will be the same.
And will there be?
Go
ahead.
I'm sorry.
Well, and then the other thing, certainly every year I have patients that are disenrolled because they didn't get the letter or the email or whatever it is. And have to reapply. I assume that's not going to change because they still have to prove that they qualify.
Well, hopefully, that's the churn issue. Hopefully, the new system will be much better able to address that. For one thing, they're going to give 12 months eligibility. Assume that is. It's not guaranteed eligibility in the sense that if income changes, there wouldn't be a change. But renewal will be required only every 12 months, which is a big improvement over every 6 months. So that ought to help folks, and it should be easier to renew, which should help. The default will be renewal. So it should help. I can't promise that the churn issue will go away entirely. Actually, that's another area where feedback would be really critical because if it doesn't get better, we need to know that and why that's happening. So feedback from pediatricians on that could be incredibly helpful, but it should get better.
Good.
At any event, in-person renewals are no longer required. Everything can be done online or electronically or over the telephone.
Great. Thank you.
Thank you.
Let's hope it works.
Are there any other questions?
There are a couple more.
Okay.
This is Tina Cheng from Johns Hopkins. Thanks for a great presentation. I think we really need to get the word out on this. But my question is, CHIP is up for reauthorization in a couple of years. And one, what is your thought on whether CHIP will get reauthorized? And two, have there been some discussions in Maryland on what happens with CHIP if it does or doesn't get reauthorized?
So clearly you think we're fortune tellers, so I'll turn this one to Lee.
Okay. Thanks, Tina. It's an excellent question, and I think number one, Maryland is in a good position given that CHIP was part of the Medicaid expansion. So it's not as though we have to put a new system together if CHIP were to be defunded. Number two, I think politically, CHIP was one of the more popular pieces of legislation to have been passed, and may have been the last really big piece of legislation with bipartisan support. But I think your concerns are well-founded nonetheless. CHIP is authorized through 2019, but only actually funded through 2015. So I think Maryland would move forward with the status quo. But that is not necessarily what would happen elsewhere if it were defunded. I think it could be a big battle. But I think the change CHIP has made in access to health insurance for children as adults, as the rate of uninsured in adults has climbed, the uninsurance rate for kids has really decreased, as you can see by Maryland's 4.6% rate. Not that that's perfect, but it's better than it would otherwise be. And I think that the other thing I would add is that as we implement the Maryland Health Connection, the bulk of the kids without insurance will be under the 300% threshold and so eligible for MCHIP. But other kids between 300 and 400% with advanced premium tax credits, but certainly with family incomes beyond that, there are still uninsured kids in that range. And we want to, which is why it's critically important that the plans available on the exchange, including the pediatric dental component, really work well for kids. It is true that the bulk of low-income kids are covered by MCHIP, but there are many other kids with needed services that will be eligible through the exchange, and which is why it is critical that the exchange not just work for adults, but work for kids as well. So thank you for raising that as an issue.
Yeah, I mean, I guess my worry is that they'll say, well, we don't need CHIP anymore. We have the exchanges, and they can go with their family into the exchange.
And I think that could well be an argument. I think the issue is going to be affordability. I think their kids, those families, and so it is really important that Maryland, as a state, as well as that we keep tabs on whether insurance coverage is affordable.
Yep.
And by looking at parents who go into the exchange, we can have a window into what that would look like if the whole family had to be in the exchange.
Mm-hmm. Thanks.
Thank you. Zenobia, did you have another one?
There is another one.
Hello.
Hello.
Hi, this is Mel Stern from Howard County.
Hey, Mel.
Two questions, Lee. One is the whole issue of coverage and access. Are we in a position to genuinely collect that data? And going forward, you mentioned a number of times how critical it is that we monitor this. Do we have a mechanism in place
Well, Mel, that is a terrific question. There are mechanisms, and you're, of course, completely right. The coverage does not equal access, and that's why the networks are so important. So in terms of monitoring, one of the things that will be monitored is complaints to insurance companies. If people can't access a provider, whether that's a primary care provider or a specialist, in a timely manner. But as we all know, those complaints don't necessarily get made either to the carrier or to the insurance commissioner, where they could also be made. We're hoping that folks will feel empowered to complain or give feedback to the navigators or assisters in the communities, or even on the call center, or through anyone who assists with applications. So there's that feedback loop. Certainly it's important to hear back from the provider community, because you all may get, we can certainly envision that you'll get feedback if people can't access a specialist in a timely way.
And that's the area that I'm concerned about. I mean, we all get complaints virtually daily about the poor delivery of one thing or the other, predominantly by insurance providers. You know, the unreasonable cancellations, the unreasonable rejections, the difficulty when it's supposed to be covered, it's not covered, understanding but the mechanism for us to then, easily forward those complaints to some central area so that we have a mass, I'm not clear on, and I think that's going forward. That's going to be absolutely critical, having done this over and over again. The constant refrain from the other side is, well, we never hear any problems.
Right.
So let me suggest, this is Lenny. So we mentioned earlier that there's been a strong stakeholder process in Maryland throughout the development of the legislation and the roadmap to implementation and so forth. And we and our friends around the state pushed very hard. So there have been advisory committees throughout the process. And so when we get to January 1 of 2014, we're in this new landscape where we have these, I'll just take one example, continuity of care provisions Lee mentioned earlier, where for a year the exchange is going to be collecting data to see if there are issues. I think our job, your job, consumer advocates, all of us, is to work together to look at that data to see if they've got the right metrics, and then to get our voice heard during the analysis and policy recommendation stage. So part of this is, we mentioned earlier, the standing committee, which we got in legislation, in this year's legislation, with a consumer focus and a broad and diverse membership. And that is an opportunity, as Lee said, to hopefully get providers, including pediatricians, on that, as well as us, those of us in the advocacy community and with policy expertise, so that we have a voice at the table, and that group will be getting the data that the rest of us may not have access to. The other part of it, too, I would just encourage that somebody, an earlier question was a question about sort of the, if I'm going to call it misinformation in the press about the defunding of Obamacare. So ramping up to October 1st and beyond, there's going to be just a plethora of misinformation in the press, and from the other side, I'm going to say. So I would urge everybody on the call to really to stay informed through MDAAP, to become individual members of the coalition. We send out information and keep resources up on our website. And Lee and I and others with the coalition would love to get stories, which are one great way to impact policy and legislators. So we can help to gather some of that data, too, to really make an impact, because what you've raised is incredibly important. And the exchange is collecting data in any number of areas, and there are new data systems set up for race and ethnicity. There are optional questions for sexual orientation and gender identity. So we have a lot of opportunity here, and we need to take advantage of it in every way that we can.
Right. And one parting additional thought, Mel, is with the ACA task force that was mentioned earlier, or work group or whatever it is for the AAP, and I've been asked to be part of that. That we might give some thought to how the AAP specifically could help in the collection of this, whether they could whether we could brainstorm a way for your membership and maybe even beyond to funnel issues into a web, some way to collect those stories and the number of issues that would be user friendly for the providers.
And I'd be happy to.
And I mean, there's the other issue of really the aggregation
right.
of all this. I mean, we can have one site that's collecting, but there are 5 others that are sort of collecting. And I mean, with the advocacy community, we've got to be able to network and and join all those complaints together.
Absolutely.
Because it is so frustrating. Year after year, we go and we all know there are problems, and we have maybe 1 or 2 stories, and from the other side, it's we haven't heard any problem.
Right.
We don't, they bring us the complaints.
Right.
So now.
Well, that's
right.
Mel, as Lee said, we really need to work together to make this work. There is, as you say, there is no central place to aggregate this information. The coalition is working with others to create a learning collaborative for the 6 connector entities to share information and get us ramped up as fast as we can with best practices for the navigators and the assisters. So building upon things like that, I think that, if we're all working together at this,
it'll work.
We got to make it work, right?
Right.
So
thank you.
I think the coalition and ACY, of course, has long worked with MDAAP, but I think we all look forward to working together. And I fear I need to bring this to a close. So everybody can get back to the rest of their work. But I want to thank Jackie Duget, first of all, for inspiring us to do this, and to Dr. Krugman for participating as long as he could. I know he had to leave. And for all of you, you'll find if you go to mdhealthcarereform.org, this will be posted with the recording. There are other presentations we've done, including webinars are available. We've done on cultural competency and health literacy, and you're now actually on our list. So later, after we get through open enrollment, we'll be doing that webinar on cultural competency and providers, and then another one on health literate consumers. So, and you can see some resources up there now that you may find useful. I really want to highlight, just yesterday, this is the way things happen, a provider toolkit was released by HRSA. I would encourage you to go take a look at that. Providers are the single most trusted messenger, and I think that there has not been enough outreach to all of you to date. And I know Lee and I look forward to a lot more engagement going forward. So, again, I want to thank all of you for joining us today, and our contact information is there, and we look forward to talking to all of you in the future and to hearing your stories and sharing information. Thank you very, very much.
Thank you.